Your Excellencies, honorable guests, dear friends, dear colleagues, dear students, good morning. It's my pleasure to welcome you at the Geneva Graduate Institute in the Maison de la Paix to the open briefing of the 78th World Health Assembly, with a focus this year on critical perspectives on multilateralism in global health in 2025. This is the 11th consecutive year that the Geneva Graduate Institute, through its Global Health Center and the United Nations Foundation, are co-hosting this important event on the eve of the World Health Assembly. We are really delighted and honored to welcome you this year again, so numerous here, to continue this tradition of dialogue, reflection, and critical engagement at such a pivotal moment for global health, but also for multilateralism in general. And let me take the opportunity of those words actually to thank our partner for this event regularly, the United Nations Foundation, but also to thank very much all the team of the Global Health Center at the Institute, who have been very busy to organize that, and also all the team of the comms and events who are present and making this happen, including on a Sunday. Global health has served as a moral barometer of multilateralism. It is a domain where cooperation across borders is of particular vital significance. One could even use the term here existential. Yet, as we gather today, we must acknowledge that this barometer is falling quite dramatically, announcing storms and dangerous weather ahead. We are living through an unpredictable period that is defined by deepening political rivalries, geopolitical divides, and decreasing resources that threaten global health cooperation in particular, but we have to admit also multilateralism in general. Through time, global health has been a site of broad multilateral consensus around the need for international cooperation, yet this consensus has come under increasing strain since the COVID pandemic, and most recently, obviously, the dismantling of USAID and the United States' stated intention to withdraw from the World Health Organization have sent shockwaves through the global health community. These developments challenge the very foundations of the multilateral architecture that we've long relied upon, and they threaten the world health ecosystem, and even more importantly, they also threaten fragile populations and communities across the world. Under such conditions, we can really ask ourselves whether the spirit of Geneva, a spirit that is rooted in dialogue, solidarity, collaboration, and shared responsibility, can survive or can be revived. This, in fact, is not a rhetorical question. In fact, it should be a call to action. If we are to navigate the challenges ahead, we must do so together, with courage, with pragmatism, in the respect of our differences, but with a renewed commitment to cooperation and co-construction. And I'm convinced that as a community today, here in this room and across here in the city of Geneva, the entire delegations present, this will be your priority and your main objective. With that, I'm delighted to give the floor to Cecilia Mundasa-Shah, who is the Vice President for Global Health Strategy at the UN Foundation, and I wish all of you a very thought-provoking and interesting discussion later, but also throughout the week. Thank you.
Dear colleagues and friends, hello and welcome to everyone with us today in this room and also joining online. My name is Cecilia Mundasa-Shah and I am Vice President of Global Health Strategy at the United Nations Foundation. I want to start by sharing my appreciation with Marie-Laure, the Director of the Geneva Graduate Institute, and to the Global Health Center for their long-time partnership in hosting this important convening. As Marie-Laure said, it is an honor and privilege to actually be doing this for the 11th consecutive year. The World Health Assembly is always an influential moment for global health policy and multilateral cooperation. This open briefing event has raised a curtain on many WHAs previewing these major milestones, the debates, and the spirit of diplomacy that characterize this annual meeting. The 78th World Health Assembly comes at a moment when WHO's financing and governance and the field of global health writ large is on the cusp of massive transformation. Decisions in the coming week will have a profound impact on the agency and its work around the world. This is a unique and difficult juncture, but it's equally an opportunity to deepen the resilience and credibility of our institutions, to enact reforms that improve efficiencies and ways of collaborating, and to shore commitments to our common objectives and invest in our collective future. This assembly presents many channels for member states to take hold of these opportunities, including new financing commitments to strengthen WHO and the adoption of a historic treaty to prevent and protect the world from future pandemics. Over the course of our program today, we will dive deeper into the consequential week that awaits. We will walk through what to expect at the formal proceedings of the Assembly, including an agenda with several hot-button issues. We'll receive an update on the WHO's prioritization process for the next biennial program budget, which was requested by member states earlier this year at the Executive Board meeting. And then we will move to a panel discussion with some of the world's leading global health experts to discuss the evolving conditions surrounding WHO's financing and governance and the broader health financing landscape. After each segment, we will invite questions from the audience, and we look forward to your engagement at those times. Without further ado, I'll now invite Professor Gianluca Bergi to the stage, Adjunct Professor of International Law at the Geneva Graduate Institute. Gianluca will provide an overview of modalities for the upcoming assembly, a preview of key agenda items, as well as a brief update on the state of play for the pandemic agreement. If you wish to pose questions during the question and answer segment, please raise your hand and we will bring you a microphone. Thanks again, and the floor is yours, Gianluca.
Thank you. Good morning. Good morning to everybody. I understand it's a hybrid meeting, so the customary good morning, good evening, good afternoon. So I'll try to give you an overview of what you can expect next week. For the veterans in the Health Assembly, this probably are things that you know very well, but for those of you that attend or observe the Assembly for the first time, it may make sense because it's a very compressed meeting, a lot of flurry of activities, and sometimes things are not terribly clear. First of all, a reminder, if this works, it doesn't work. Okay, how do... Okay, let's see, it works now. Okay, just a reminder, the Palais des Nations, where the Assembly takes place, is still very much under renovation. And so the space the WHO rents to run the Health Assembly has shrunk quite a bit. So, for example, the plenary hall, the Assembly hall where the plenary of the WHO takes place is under renovation. So the plenary will probably take place in the beautiful room of the Human Rights Council or a similar room in the new part of the Palais, so-called Building E. Just to say that the space has shrunk. I'm not saying this just as a point of information, but because it has consequences for non-state actors and the public attending. They have less space. Sometimes they have to go into a room and look at a screen. But at the same time, the proceedings are webcast of the open meeting. So even if you cannot be physically there, you can follow what is going on. So in my presentation, I will cover these 4 points to give a bit of a sense of what's going on next week. Starting on the participants, because again, you go to the Palais and you see an army of people running around. Who are they? Why are they there? On what basis are they there? What are the rights of participation? It's not self-intuitive, frankly. So first of all, obviously member states. That's the moment of glory, the plenary of WHO. WHO is 194 member states, but I don't remember ever an assembly with 194 member states present. For some of them, in particular small island countries in the Pacific, it's an incredible challenge to come to Geneva. But many of them come, and they travel 3 days in economy to be here. So that gives you a sense of the importance of the assembly for them. It's a moment where they can be heard, but also the moment when they can network, they can build alliances. So that, I think, gives a sense it's not just a ritual, it's something of political importance. Ministers of Health head the delegation. Sometimes they stay only for one or 2 days. Other times they stay for the whole duration of the assembly. In particular, if they come from far away. Once you're in Geneva, I think you tend to remain until the end. The size of the delegation changes dramatically. And this year, apparently, and I give it to you secondhand because I heard it secondhand, the historical record will be set by China with almost 170 persons on the delegation. They are not all state officials and diplomats. There are members of parliament, experts, professors. There are many students that come here and do the footwork, and it's a learning opportunities for them. But 170 is a big logistic achievement. I give to you also secondhand another less, more negative news, that apparently the United States for the moment has not registered any delegation. So if that doesn't change, it will be the first assembly since 1948 without the United States. I think quite striking. Besides member states, we have many international organizations. This year, on the agenda, there is a conclusion of an agreement with OECD, the Organization of Economic Cooperation and Development. It is on the basis of an agreement with WHO that the international organization can attend. Palestine and the Holy See are in a class of their own because they've been invited by the Health Assembly with ad hoc resolutions. And the rights of participation of Palestine, they've been increased dramatically last year. They're almost like a member state. They can sit among member states. They can be elected as presiding officers. They're really inching towards membership, but not yet. We had other observers, like the International Committee of the Red Cross, invited by the Director General, and then obviously the public and the media. This is not just an event for the insiders, it's a public event. And as I said, unfortunately, with the limitation of space, but still, there is a lot of public participation and interest. When it comes to non-state actors, the participation has been codified and rationalized in 2016 when the Assembly adopted what we call FENSA, the Framework of Engagement with Non-State Actors. It has categorized non-state actors in 4 groups. NGOs that are largely professional NGOs like medical, hospital, nurses, and public service NGO, International Business Association, first and foremost IFPMA in the pharmaceutical sector, philanthropic foundation like a Gates Foundation, and academia. Of these 3 can be admitted into what we call official relations by the executive board. When they achieve that status, they can participate in governing body meetings, in particular the Health Assembly. In the philanthropic foundation group, I think only the Gates Foundation has been admitted so far, but I could be wrong. One point is, why non-state actors are here? It's expensive to spend a week in Geneva. Sometimes, if you know the Health Assembly, they are squeezed at the end of the meeting. They have 1 minute to make a statement. They're very frustrated. But to me, and I stand corrected by the non-state actors in the room, and I see several, the main interest is to be physically here and to share the same space with member states and so on, because that's a golden opportunity to contact them, to lobby the position, to brief them, to support them, to build alliances. And so in that sense, the COVID pandemic, when the assembly was totally virtual in 2020 and 2021, was a disaster, because it really totally curtailed that space of physical presence. And so it's good that things are back on a normal keel. How the assembly works. First of all, the WHO has the shortest assembly of the whole UN system. As you know, it's like 5.5 to 8 working days, compared with the General Assembly of the UN, which is in session 12 months. It adjourns the day before the new session. So it's very compressed. There's a lot of activity at the same time. It's very stressful, very demanding. There have been attempts in the past to extend the session, but it's always been resisted because too much cost, and I think it's a plausible argument, even if it lasted 1 month, it would be the same scramble. It like fills the void. So it's going to stay this way. So for small delegation and first-time participants, it can be confusing, and it's just a practical detail, but it's very important. The Secretariat has set up an app you can download on your phone. It gives you real-time information what is discussed where. And for small delegation, it's very important, because if they need to be in the room for item 8, and they know when it takes place, that is tremendous practical importance. So who presides the Health Assembly? the Assembly as such, one president and 5 vice presidents. This year, the president is the Minister of Health of Philippines. And the 2 committees also have their own presiding officer. The point here is that everything is rotating regionally. As you know, WHO is very regionalized, there's 6 regions, and there is always a lot of attention to calibrate regional representation at the level of presiding officer. The second point, and I experienced it firsthand as former legal counsel of WHO, is difficult to find good chairs. Good chairmanship is an art, and sometimes you have disasters, but you also have skilled individuals that have the art of reading the room or trying to get consensus, and it can make a tremendous difference. So fingers crossed that we have good chairs, in particular in the committees this year. So, sorry, I think I took. Okay, so the assembly is broken down in various parts, and you will see them as you attend the assembly. The plenary is the most solemn, the most formal one, but also, for many observers, maybe the less interesting, because most of the business is transacted in Committee A and Committee B, the 2 main committees. The plenary does the housekeeping, it has a lot of speeches, what we call the general debate. It adopts finally the resolution, but it's fairly formal, and it meets occasionally during the week. So the main business is in Committee A, which is a programmatic committee, including the budget. The budget is not a financial issue, it's a programmatic issue, so it's in Committee A. And Committee B, which is the administrative, legal, financial committee, but also for a long time has the item on assistance to Palestinian population as a first item of business. So Committee A is busier than Committee B, intuitively, and items sometimes are shifted to Committee B. And that's why it's very important for more delegation to have a chance to know that this happens, because otherwise they may miss the reason why they are in Geneva. There are other bodies. As you can see, there's a credentials committee, which is normally short and bureaucratic, except when you have political problems, like 2 governments trying to represent the same country at the same time. We had a problem in Libya, for example, in 2011, this kind of thing. Then become very political. And the General Committee, which is a bureau, if you want, of the Health Assembly, meets only twice during the Assembly. And again, it's normally pretty bureaucratic, but it has to look at the agenda, including supplementary items, things proposed at the last moment. And for the longest time, there is always an item on inviting Taiwan as an observer. As you can imagine, there's a controversial, there is a lot of debate in the General Committee. So to address the problem of small delegations, the Assembly decided a long time ago that there would only be 2 parallel meetings at any given time. So either the plenary and the committee or the 2 committees, but only 2 formal meetings. So what happens during the week is that there are many drafting groups or working groups set up, in particular to try to agree on resolutions. And so in reality, you may have 3, 4, 5 parallel meetings, sometimes in parallel, sometimes meeting in the evening, in the morning, over lunch, and that's, once again, is fairly demanding on small delegation, but that's essential to arrive at an agreed conclusion in a short period of time. What happens in Geneva is that as you know, Health Assembly, the Global Health Week. Anybody who is anybody in global health tends to come to the Health Assembly. So sometimes there are more things happening outside the Palais than inside the Palais. Meetings, events, workshops. There are many things you don't see. There are many bilateral meetings, ministers that talk to each other, either in a private room at the Palais or in a hotel, and sometimes states that they cannot be seen talking to each other in public. They can talk to each other in private during the Health Assembly. So that's very important, because that's multilateral diplomacy writ large. It's not just what happens in Committee A and B, but really what happens in Geneva at large. So I think I can't emphasize enough how important it is. Plus, we have multiple side events, including those here. So I hope you will come. For the next 3 days, we have very interesting panels at lunchtime. So let me maybe start with this. So you look at the agenda of the WHA. It's on the website, and you wonder, why is this stuff there? Who decides where those items are on the agenda? So in principle, the executive board that meets in January is a gatekeeper for the agenda of the Health Assembly and approves what we call the provisional agenda. But if you look at the agenda, there are a number of groups of items. There are new items that are normally proposed by states or by the Director General and are filtered by the Executive Board. There are what we call statutory items that come back every year because they must come back every year, like human resources, financial reports, the audit reports, and so on. There are recurring items that are decided by the Health Assembly. For example, adopt a resolution saying Director General report in 2 years. And so the item comes back in 2 years and so on. So there are things that keep coming back because that's how the Assembly has decided. There are supplementary items, as I said. Also this year there is an item on participation of Taiwan as an observer. Progress reports that are only considered in Committee B. You think it's an absolutely boring thing, but there is a lot of discussion because these are items of great importance to many countries. Just not a decision attached to it. It's just an information. And then finally, it's a novelty of the last few years. There are many strategy plans of action that are not adopted for perpetuity. They're adopted for a period of time. So the year before they expire, they come back to the Health Assembly. So the Assembly can decide whether to let them die or whether to extend them. So there are quite a number this year. So if I can go back to how decisions are taken. The Assembly is to take decisions, not just to talk and to exchange views. So resolution, first of all, can only be introduced until Monday evening. In the past, there were surprises. Delegations that introduced resolutions on Thursday, the day before the adjournment, creating a lot of havoc. And so they try to regularize and to make things more predictable. The resolutions are often negotiated informally in Geneva by the permanent missions, and so they arrive at the Assembly half agreed or just with few problems to be solved. For example, the resolution adopted the pandemic agreement has been negotiated in Geneva for the last few weeks, and we have an agreed text. They are discussed in the main committees. Again, sometimes they are adopted right away, sometimes they require drafting groups, working groups, and so on. There are many informal consultations, even in the coffee shop, with a small group of people that try to iron out the differences. And then the final adoption takes place in plenary, as I said. The dogma in WHO, and I think across the UN system, is consensus, is avoiding a vote, avoiding a formal vote where states are forced to say yes, no, or abstain. There are items where there is always a vote. For example, elections, or the item on Palestine. Since 2022, there is an item on Ukraine, where there is always a vote. There are competing resolutions. And we noticed for the last few years an increase in votes when questions of gender come up. So there has been, in a way, politicization of this resolution on questions around gender. So coming finally to the main issues, I'm a lawyer, so I'm not a public health person, so I may have missed important items that have not captured my attention. But if you look at the governance and political side, first of all, obviously the budget is a big ticket item. Because of the loss of the US funding and the number of reasons, the budget has been sharply reduced. What you see on the screen is the overall envelope. And if you follow the media and so on, you will have seen a lot of different figures, which is quite confusing. But this is a total budget envelope. It goes down from 7.4 to 6.2. What is important for WHO immediately is what we call the base segment, which covers most of the mandated activities of WHO and the staff costs. And that's gone down from 5.3 billion to 4.2 billion, so quite a cut. That's the bad news. On the good news side, the Assembly decided in 2022 to bring back the ratio of voluntary to assessed contribution that was totally skewed, where 17% assessed, 83% voluntary, which is dysfunctional for an organization like WHO, to bring it back to 50-50 by 2030. And so this was the decision in principle. The states had to agree at every budget. They agreed in 2023. There was anxiety now because of the financial crisis, but there is an agreement to have an increase. And I must say the engineer of the decision is sitting with us, Dr. Björn Kummel from Germany, that really was instrumental in shepherding that decision. And then there is an item which, as you can imagine, is quite sensitive on how to investigate allegations against the Director General. That came out of the recommendation of the Joint Inspection Unit. As you can imagine, it went on for a long time. I invite you to look at the document. I don't have the time to even summarize the process, very complex, to ensure due process, balance between investigation, the role of member states, and so on. But there is a final draft ready for adoption. And then finally, and that seems like something of limited importance, but Indonesia is asked to move from the Southeast East Asia region to the Western Pacific region. As you know, WHO, as I said, is very regionalized, but regions are not cut in stone. States can move from one to the other. There is a process to go about it. The reason I'm mentioning it, because it's creating quite a bit of anxiety in the Southeast Asia region, which is the smallest one. It has 11 members, losing Indonesia 10 members. And so some people say, why do we need the region for 10 members? But obviously you have India, with the most populous country in the world, and so on. But just to say, there were some ripples in the regional committee in last year. And then finally, I mentioned Taiwan. There will be an item on Ukraine, and there are 2 items on Palestine. One in Committee B, the one I mentioned before, but one in Committee A. They come from a special session of the board 2 years ago, and so there will be quite some fight. In particular, I think Israel will try to consolidate it into one item, not 2, also because there's quite an amount of overlap. So that will also be predictably a fight. Finally, programmatic items. Obviously, the big one is the adoption of the pandemic agreement, which starts a whole new set of work, because there will be a new working group working on an annex on pathogen and benefit sharing, preparation for entry into force, and so on. But it's a very important milestone, the second treaty adopted by WHO, and whether or not you like its content, I think it's an important statement of multilateralism at this time. For the rest, we have the climate change. We have a global plan of action, which was mandated last year. It's ready this year, so it's been very fast, and it's quite ambitious. I think it's important because WHO has been missing a little bit in the climate change discourse. And so now I think it's positioning itself at the center of this important agenda. Otherwise, you have traditional medicine, a strategy for adoption. You have antimicrobial resistance, a very important 2015 Global Action Plan, which is up for an update. So quite a number of important programmatic items. The last thing that people sometimes forget, as you may remember, the international health regulations, which are the main instrument we have on the shelves right now on health security, was amended in 2024. The amendments will enter into force in September 2025. So we are very close to a new cycle of life for the regulation. There are several institutional aspects. The amendment creating new bodies, new processes, and so there is quite some work to do, and I hope that my colleagues in the Secretariat are busy preparing what will be probably politically difficult decisions for the Health Assembly and member state. Finally, and I have 20 seconds to go, the question of the costing of new resolutions. That's not a new item. For quite some years, the Assembly adopts a resolution that don't clearly have funding behind them. There is always a document where the Secretariat gives a costing of the new resolution, but then the Assembly adopts them. And so the fiscal discipline has been limited. It's becoming more urgent now because of the budget crisis, so I think there will be language in this resolution that makes them conditional to raising sufficient funds. But obviously, these are mandates, and so the Secretariat has to do what it can to implement these mandates in the face of a financial crisis. So I'll stop here. I stay within my 20 minutes. I understand there are 5 minutes for questions and answers, if any, and I'll be happy to. First of all, I hope it was useful, especially for the first timers, and happy to see if there is any question. There's a question there and a microphone coming. On this side? Otherwise, just speak loud and.
Thank you. Good morning, everybody. My name is Papa Sek. I'm the president of PRESOD, International Initiative, which is an initiative to prevent zoonotic disease, which pandemic potential. So, PRESOD. Thank you. PRESOD is relevant stakeholders in the INB pandemic treaty negotiation, and we push really for member countries to include one health approach, but also prevention in the pandemic treaty. And that was really a big result for the first time in the world. So I would like here really to congratulate WHO and all member countries and organizations also. We should really push behind to be able to have these two items in the pandemic treaties. So you talk about the pandemic agreement, and when will it be adopted? It is in the agenda, so I would like to know really when.
When it's adopted?
Yes, because it is very important, and also the way forward. If you can say more about the way forward, you say something about the working group for pathogen sharing and benefit also sharing. So I would like to know more information about it. Thank you so much.
Thank you for your question. First of all, the game plan, as I understand, is for this item, for the pandemic agreement, to be taken up in Committee A on Monday afternoon. So the committee will open, will elect its chairs, and the first item will be the pandemic agreement. There will be a hopefully compressed set of speeches, and then the Committee A will adopt the draft resolution that will go to plenary on Tuesday morning. For a very short adoption, and then probably speeches later in the day. But the main action will be in the Committee A on Monday afternoon. Very quickly, because I think time is running, the resolution will do a number of things. We'll adopt the agreement, but will not open it for signature, which is very unusual. Normally treaties are up for signature ratification. Instead, they are putting on suspended animation. Why? Because the Assembly will set up a working group open to all member states to negotiate what we call an annex on pathogen and benefit sharing, which is a linchpin of the agreement, but it could not be agreed in detail. So the agreement is very, very general, and everything will have to be negotiated and fought up in this working group. Once the annex is adopted, the agreement will be unfrozen and open for signature together with the annex. So it's a quite unusual process, but it's the only way to have this political package coming together. Plus, the working group will have to decide on preparing the first session of the Conference of the Parties, which takes a lot of work, and also working on some of the institutional aspects of coordination financial mechanism, on the new supply chain network. So we plenty of work to do. And the deadline for the annex, which I find quite ambitious, but you never know, is the Health Assembly in 2026. So watch this space for 2026. So thank you very much. I think my time is over. Many thanks for your attention.
Thank you, Gianluca, for that comprehensive overview of what's in store for this clearly action-packed week ahead. Turning now to WHO's prioritization process, I welcome to the stage Dr. Jeremy Farrar, WHO's Chief Scientist and incumbent Assistant Director General for Health Promotion and Disease Prevention and Control. Over to you, Jeremy.
Thanks very much. Thanks very much indeed. I've been at WHO, what now, 2 years, almost to the day. I wish I'd had that talk when I started. Because it puts into the whole context the rest of the week. So thanks very much. It should be mandatory listening for everybody involved. So I'm Jeremy Farrar. As of today, the Chief Scientist at the World Health Organization. That's about to change to some other more complicated title, but for good or bad, I'll be with you at the WHO for the next couple of years, I think, and look forward to what I think is going to be very tough next 6 months, 12 months, but from which organizations have to reform and they have to evolve and they have to emerge stronger. And that has to be, that's not a corporate view, it's not an institutional view, it's a personal view. Before I start with what will turn everybody depressed, I think it is important just to reflect in this time when it's difficult to watch the news sometimes, just on what is likely to be achieved this week. And I'd pick out two things, both of which have already been mentioned. At a time of fragmentation and geopolitical tensions, the fact that 193-4 countries have come together to, in theory, approve a green-lighted pandemic accord is a remarkable achievement. And I appreciate there are complexities going forward of ratification, and we heard the PABs, the pathogen sharing and benefit sharing, are still to be approved, but nevertheless, that is a huge achievement, and everybody involved in it deserves enormous credit. And the second is again, hopefully, to be going forward, is the increase in assessed contributions, which, as I said, Dr. is it, Bjorn in the front row, deserves enormous credit for, but so many others as well. And those two things together really do have to give you a sense that actually multilateralism death is grossly exaggerated, and it still has a role. And you have to hold on to that optimism and hope, because otherwise, frankly, it's difficult to see anything other than slightly nihilistic future. And if you give in to nihilism and pessimism, then the arguments for a better world are lost. So no matter how hard it is, once you get over your grief, personal and professional grief, and I'll come back to that of just the impact the current disruption is having, you have to come through that era, because you will not, or at least I personally, cannot be creative in terms of thinking of how do we address future challenges once you're in that depth of despair. So all of us have to push ourselves to move beyond the grief that some of us certainly feel. Because the world does face some enormous challenges. You know what they are, from climate change to demographic shifts to inequality around the world. And if we allow the fragmentation to continue and we lose the sense of collective ownership of these challenges, then I think the 21st century is going to be extraordinarily hard. Equally, at the same time, and I speak now as the chief scientist, we are in a scientific golden age. Unbelievable progress, in my view, not just in the life sciences and biomedical sciences and public health, but across the whole field of science, some of which we like, and of course some of which bring enormous challenges with the coming of things like synthetic biology and mirror biology and other things. But they will, all of those sciences, from the social sciences through to the life science, help address, not the only answer, but they will help address the great challenges of the 21st century. I think our biggest challenge is not the technical challenge of the scientific advances, it's to ensure in the 21st century that science drives greater equity, and we do not allow science to lead to greater inequity. And there is a very real danger of that. As science increasingly goes on in a smaller number of countries, both in the public and increasingly in the private sector, and in the private sector in private hands as opposed to public limited companies, that doesn't allow transparency. And if we allow science to drive, if we're passive in how we allow science to drive, then science, I fear, in the 21st century will lead to greater inequalities. The impact of this current phase of disruption is really profound. And we are all we're slightly insular looking at the moment in Geneva, and we're looking in our own organisations. But if you look at the impact that the changes in the way global health is funded at a country level, at actually what is happening in health clinics around the world, in all countries, but particularly low and middle income countries, it is staggering. And the impact of that, even if they were reversed quickly, will go on for many, many months and years. In fact, if you look at HIV therapies and the withdrawal of some of that support over the last few years, over the last few months, then that will lead to more people with HIV, it will lead to more people with higher viral loads of HIV, it will lead to more transmission of HIV, and you'll have another growth of HIV around the world. Sorry for that, I didn't realise the glasses were upside down. So we shouldn't just focus in a complacent way with how this is affecting those of us in WHO, and it will, or in other UN agencies, it will have a profound effect. The impact at a country level is very profound. It will be more challenging than people think, and it will be more long-term. At WHO, the changes in WHO and the current plan that the United States will withdraw in January 2026, remember they have announced that they will intend to withdraw, but it is a 12-month period, so they won't officially withdraw to 2026. But nevertheless, the impact on the financial hit on WHO is profound. Something like 20 to 25% of WHO funding comes from the United States, and that will lead to profound changes in how WHO can function. Don't underestimate the non-financial impact of the US withdrawal. The US provides 12% approximately of all experts to WHO committees. You can't instantly replace that because the expertise is deep, it's been long-standing, and it's been hugely appreciated by the WHO and all countries around the world. And of course, most people think of the Centre for Disease Control in that, they think of NIH. I would just like to call out the Federal Drug Administration. Their impact around the world is huge and has been long-standing and has helped many countries, regulatory agencies, rise to the level of international standards. That withdrawal will be a huge cost. It is also an opportunity for other countries, many experts have grown in the last 10, 20, 30 years all around the world, to step in and lean into that. And I'd call all countries to see that as an opportunity, not to replace the US, because we sincerely hope they'll come back, but to provide expertise to the WHO from your own countries to allow expertise to be more diverse and more inclusive. So I've been very involved over the last 3 months, really since the beginning of the year. There's been 3 processes at WHO. There's attempts, and they've been profound, and they've had an impact. Efficiency gains, resource mobilization, but it was always clear from the very start that those 2 changes were not going to square the circle. You could not get to the financial place you wanted to get to and emerge as a better organization without asking yourself the fundamental question, what is WHO for? And that is a profound question to ask, which, of course, the member states will ultimately hold the decision on that. But the Secretariat needs to lead that discussion and ask ourselves, in the future world, rather than in the past world, what is the role of the World Health Organization? And inevitably, as with many organizations, it has grown over time. It has taken on roles and responsibilities that there are others potentially in the world that could do. And actually, the global health architecture over the last 10, 20, 30 years has dramatically changed. At the end of the last century, essentially it was the World Health Organization in the partnerships of the world. Now there are many other partners with a lot of capacity to do things. And also, and we underestimate this, countries have changed as well. I spent 20 years living in Vietnam. If you look at Vietnam in 1995 when I first went there, and you look at it in 2013 when I left, it's a profoundly different country with different capacities at both academic, scientific, public health and policy-making decision. And Vietnam is not alone. So WHO is not now working with the same countries it worked with 30 years ago. It's working with a very different set of countries. And therefore, WHO's role in the world must change. It's been a mantra of mine in all my professional career that you should reform before you feel you're forced to reform by external events. Unfortunately, very few organizations do that, very few, some in the commercial sector. But mostly those that don't tend to then drift, not WHO, but then drift in the future into almost oblivion. Reform before you need to would be my advice, but if you can't do that, the next best time to reform is as soon as the pressure is on, and that is now. So what has that meant at WHO? Firstly, there's been a very detailed bottom-up exercise across the whole organisation in countries, regions and headquarters as to what is the real role of WHO. That has run its course, and now we need to take that and add on to that a strategic overlay with member states to say what actually is the role of WHO. That had to be also, in parallel, done with a reorganisation of restructuring as you think of the functions, what structure do you need to deliver it. And as briefed or leaked, Healthcare What, or whatever that journal is called, tends to have the information before those of us in WHO do, sometimes right, sometimes wrong. But I'm sure that some of you will have seen the changes, and they are profound. We always argued internally that the changes and the functional changes must start with the leadership. You cannot change an organisation just by removing 10 or 20 or so % of staff at the so-called lower levels of the organisation. It has to start with leadership. And the announcement this week of going from 11 members of the executive to 6 is a profound reform. That is not an easy thing to do. When you think of both the competencies of that group, you think of the nationalities of that group, you think of the dynamics of that group, to go from 11 to 6 is a powerful reform. I believe that it will also lead to a profound change, and this is no criticism of the current or the past, but if you have 11 divisions, and the word division tells you a lot, if you have 11 divisions in an organisation, you inevitably end up with a lot of duplication. Because in the way WHO is funded, where there is a small core grant and then a core award, and then people gain money from the outside for particular projects, there is a tendency, as in all organisations, to grab a bit of money, put it into your team, unit or division, and hold it. We have to change that model, and the assessed contribution change will allow that to happen. But with 6 Divisions, I hope they'll be renamed not divisions, but clusters or something different, because division tells you something about a way an organisation is organised. We will be, not perfectly, but we'll be able to do away with some of that duplication. And then you must look at the duplication between headquarters, regional offices and country offices. And it's already come up in the earlier conversation of the complex structure, federated structure of the regional offices. So what does that actually mean? Well, firstly, we've learned a lot about ourselves. I don't think anybody in the organisation would have been so aware of the levels of duplication at a formal level and with data than was previously known. And some examples of that: infection prevention and control is scattered across many different parts. Data, digital and surveillance is scattered across many parts. Communicable diseases and immunisation is scattered across many different parts. And there are many, many others. In an era of multi-morbidity, to have cardiovascular disease, metabolic disease, infectious diseases, mental health split across multiple divisions doesn't really make much sense when an individual patient or a community or a public health approach has got to be integrated. So as we go from a vertical set of systems into a more horizontal set of systems, I think you will remove a lot of the duplication, both internally within WHO and, critically, as I mentioned, externally with the external partners with whom we work, Global Fund, Gavi, CEPI, and all of the others. In addition to that, there has to be a look, and this is a discussion which is starting now, in the future going forward, not the past, what is the future of the global health architecture? How does it come together in 2025, 2050? Because the current structure, I do not believe, is going to be sustainable. They've emerged, all of the organisations, and including WHO's new role, into a world that was defined 20 or so years ago. That is a different world going forward, and we need a different set of actors and a different set of partners, and we have to forge a way that they can work more collaboratively together than seeing themselves in competition with each other. I do believe that WHO is at the centre of that, but I do believe WHO has to be a generous centre, where it is quietly confident with humility about its own capacity that it can facilitate the work of others rather than be in competition with them. If you could forge that global health architecture which respects the countries and the ability of external partners to do their job, and you define what WHO's role will be, I believe the global health architecture will emerge in a better place than it has been to date. That means redefining WHO's core values, core mission, core functions, and core structures to deliver it. And then more broadly, that also builds into the UN 80 reforms, which are also much needed, about how the UN system works across, where there is also massive duplication, which we need to root out. So WHO, I believe, will go through an incredibly difficult, at a human level. If you think that 20 to 25% of our colleagues will lose their jobs over the next 6 to 9 months, that's extraordinarily difficult for any organisation. It'll be a human issue, not a technical issue. And we should never forget the human side of it when we talk about reductions. We will emerge, I believe, in 26, smaller, more focused, back to our core mandate, and I believe better. That is the challenge that we face ourselves with. And then finally, to say, everybody in this room, and apologies to some who may have heard this before, everybody in this room, although you may not feel it, has agency and power. We are a privileged group. It's a privilege to be in Geneva. The question is not what you say in warm words in plenary discussions over the course of the next 7 days. It is what you do when you leave here over the next 12 months that makes the world a better place. So don't hide behind the warm words. Do what's necessary and do what you say you'll do, and then we will emerge in 2026 stronger than we are today. And I take it back to the pandemic accord and the assessed contributions. There is hope, there is optimism, and we will do better. Thank you.
Thank you so much, Jeremy, for sharing your insights and outlining the current thinking and approach that WHO is taking to address its evolving challenges. We know these are very busy times, so we really appreciate you being here today, and understand if you have to leave before the event concludes, but really appreciate having you here. And we're now moving to our panel. And I'll invite our panelists to please join me on the stage.
We seated?
Yes. Yes, go ahead. This is working. Can you hear me? Is this working? Yeah? Okay, perfect. Thank you. We are really honored to be joined today by such an esteemed panel of global health experts. Let me start by introducing Björn Kimmel. He is the head of the Global Health Unit within the German Federal Ministry of Health. Björn is an expert in WHO reform, finance, and administrative issues, and we're grateful to have his thoughts on those topics today. Also with us is Suwit Wibumpam Prasert, Senior Advisor at the Minister of Public Health of Thailand, bringing experience for over 3 decades working on public health from the grassroots to the highest policy level. And we are joined by Professor Ilona Kickbush, founder of the Global Health Center at the Geneva Graduate Institute and chair of the International Advisory Board. Ilona carries a distinguished career within and alongside the WHO. I am thrilled to be speaking with such an experienced and insightful group about the critical assembly that gets underway tomorrow. So building off of what we learned today, listening to Gianluca and Dr. Farrar just now, I want to dig deeper into the implications of the discussions and decisions we expect to take place this week. So starting with you, Björn, every year the number of agenda items and resolutions of the World Health Assembly underscore the value of WHO as a forum for member states to advance global and national health priorities. Recognizing the budget crunch WHO is now facing, how will global health priorities get articulated through the World Health Assembly? Do you foresee member states deploying this global policymaking forum differently than before?
Well, thanks a lot for the question, and thanks a lot for inviting me. It is, well, a very relevant question and interesting question at this moment, obviously following the 2 presentations by Gianluca and Jeremy Farrar. It's a broad agenda that we are facing in the Assembly. I think it's a very specific Assembly, and I think both of them have alluded to that already. The number of agenda items, I think in my team we refer to 75 different agenda items with lots of sub-items, so it's almost impossible to keep track of the entire thematic focus, and I think it shows more or less the broad interest of member states, obviously, in WHO and the World Health Assembly. But I think what is obviously key at this current moment is the big crisis that Jeremy has referred to. WHO faces a severe financial crisis. We, as the German team, have argued that we should restrict ourselves to less, adopting less resolutions. I think we argued that it, to us, doesn't make much sense to keep bringing further and further and further resolutions to be adopted by the World Health Assembly with not knowing whether they will ever be implementable. Jeremy was referring to the fact that most likely every 4th staff member of the organization will have to leave the organization by the end of this year. And that does not only apply to headquarters, but basically throughout the entire system. I'm not sure how many staff members are here, but it's really frustrating. Everybody is shocked, more or less. They have their families here or elsewhere. So this is not an usual assembly that we will see. It's a assembly in WHO in a very severe status at this moment. And 25% is what we know at this moment. We've just had the PBAC, so the committee that focuses on finances and administration. And although Germany is quite well informed about the finances normally, we were slightly shocked by what we heard, because basically we are spending much more than we actually have. So there needs to be a consolidation course. We had hoped for this to have been implemented a little bit quicker. We are grateful to the DG that he has now started the process, obviously with a new organigram, with a new structure, and having announced the new senior management team. I think that's exactly what we need now, but further steps need to be implemented. It's certainly not that nobody wants to sack people, but it's a given fact that basically we're spending too much money. We need to make sure that WHO enters the new year with an equal balance. I think this is really a major challenge. So basically, your question was indicating that the broad subjects and resolutions might be something positive. It is positive because obviously we're trying to drive change through adopting resolutions, but it's also challenging sometimes to realize that member states are not fully aware of the severity of the financial status that WHO finds itself in.
Thank you so much, Bjorn. Certainly the consequences ripple beyond Geneva, and I appreciate you highlighting the issues about capacity, how important that is. So now a question to you, Suit. As fiscal space for global health contracts, many important priorities will be competing with finite resources. How can member states and WHO ensure that countries' needs are recognized and reflected through the transformation that is now underway?
Thank you. I have been with the World Health Assembly every year for the last 28 years. I remember that in early 90s, the WHO biennial budget was mere 1.2 to 1.5 billion. 2/3 to 70% were from assessed contribution. The WHO was very well then. It's like a lean and fit organization. Then because of we eat too much sugar, fat, and do less exercise, become very obese, very obese. And now this may be the time to become fit again. That's why we have the 2022 resolution to expand assessed contribution, right, to 50% of the core base budget. That's a very welcoming resolution. But it will not achieve that unless we reduce the total budget. So it's time to keep fit. Why worry about the budget? The WHO has budget is so small. You ask about the country. Country doesn't depend on the WHO budget. As compared to national budget. Back 30, 40 years ago, most countries are still low income. Now they are all middle income. Their budget is much bigger. So what member states want from the WHO is the name and the brain, social and intellectual capital, not at all the money. I don't understand why we care so much about people leaving the WHO. They find their own job anyway. if they are good enough, right? If they are good enough, they can find a job everywhere. And you used to be only 1.2 to 1.5 billion. Why can't you go back to that level? Thanks to Trump. It's a blessing. And the priority health issue in the country is not belong to the WHO. It's belong to me, my country. I have to set my own priority. I have to mobilize resources from my country to solve my problem. And not only money, but social intellectual capital of everyone. And nowadays, the technology is very good. Individual people with one click, he or she can learn everything. Not even have to ask the doctor, something like me. Sometimes they know even more than me. The world has changed. We need to, have a new business model.
Thank you so much, Suit, for sharing some concrete actions and that governments can take. And I want Ilona to build on what you said about what's needed from WHO. So the current disruptions to global health are unprecedented, but might these challenges to the status quo unlock system-wide improvements and can deliver more impact and save more lives? What do you think are the activities that WHO must focus on to add the greatest value in this dynamic and unpredictable time?
Well, thank you for asking that. And it actually follows through from everything that Jeremy has said, Suvit has said, Björn has said. Point one, we're in a totally different time. And I still think a lot of the discussion doesn't take that into account. The politics have changed, power has changed, where innovation is located has changed. I've just come back from India. It's absolutely extraordinary what's going on there. The ability, as you say, to access information has changed. So what is needed now, and that is the big strategic challenge first of the group and the secretariat that Jeremy has alluded to, is to say, what does this all mean for us, and what do we have to offer? And then it leads to what Subit said. If this is a smaller organization and one focused on, let me just call it the normative functions, even though many people don't agree or don't understand what they are, but then it starts to become tangible what that intellectual capital of the WHO could be and what it really offers member states. And that intellectual capital has to be brought together with the member states and their needs, with that normative function. Where do we need norms and standards, for example? What about algorithms? Who do health data belong to? We always focus on the pharmaceutical industry. Yeah, what's the role of the big technology companies? The world, what's it called? The WHO Foundation is doing a big event with TikTok. I just thought, there are no rules and standards in WHO in relation to the cooperation with one of the richest and most influential industries in the world. You can hardly talk to a pharmaceutical industry representative, but you can have a meeting with TikTok. So I think, there is a lot of challenges out there that, you need intellectual capital, you need norms and standards, you might even need new treaties, and where you bring the member states together. Just one more sentence on that. There's a lot of reform, hopefully now going on in WHO, but that reform has to be paralleled with what is going on in member states. Do member states understand WHO? I would put on this table that many member states don't. They don't know what a normative organization is and what they really want from it. And I think here is something where the dialogue with member states is so important in shaping what Jeremy has said. We put forward a proposal, and then the discussion with member states will finally shape the organization. But that means that discussion also has to happen in member states, what kind of WHO they want.
Thank you so much, Ilona. That was very insightful. Unfortunately, today, Ms. Joy Pumafi was not able to join our panel, but I have a question for her that I want to pose to the group. As we all know, member states have just completed negotiation of a new legal instrument for pandemics under the auspices of WHO. We've undoubtedly hit a huge milestone with the text being agreed in principle, but there is still work to be done. The pathogen access and benefit sharing mechanism still needs to be negotiated. What are the headwinds we still face, and how might the expected adoption of the agreement later this week put wind in the sails of diplomacy? I don't know who would like to start with some reflections on that. Anna? Jorn? Yeah?
A member state.
A member state.
Okay. So I had the pleasure to be part of the pandemic agreement negotiations, I would say, for the last 2.5 years. For half a year, I, for some other reasons, was unable to attend, but I think I attended most of the meetings, and it was interesting to see the different and the shifting dynamics. So at the very start, full enthusiasm and full commitment of all member states to bring this over the finish line in record speed time, I would say. The timeline from the very start was too ambitious. To finish this in 2 years, almost no other international agreement was as quick. But I think also the Secretariat really was desperately longing for the success. Now, throughout the last year, the final year, there were lots of moments where I thought we're not going to make it. Yeah? Why? Because I think to a large extent, the political momentum had gone. Not against WHO and not against global health, but I think everybody was fed up with addressing pandemics. I mean, in the German context, I can say that, but I think the same will apply to many others, that there are internal debates on how we dealt with the pandemics, and basically the citizens don't want to hear about pandemics anymore. This is something they want to shift away. So you're not going to be a superhero finalizing a pandemic agreement and bringing this more or less to the broad media, at least I think in a Western European scenario, I would say. And I think you could see this and sense this in the negotiations. So there was, to some extent, this missing political momentum. I think there was then, again, a new political momentum with the change, obviously, in the US administration, because this was seen as a strong vehicle to clarify and send out the signal that multilateralism is still alive and that we are, despite the geopolitical settings, able in WHO and beyond to conclude an important milestone for the future pandemic agreement. Obviously, the job is not finished, and I think that's important to realize. We had the question before. So we are not going to sign or ratify the pandemic agreement. Nobody can do that. We can only do this once the PAPS is finally negotiated. And that was the consensus in the INB. The PAPS is an integral part, so the pandemic agreement cannot live on its own, neither can the PAPS. They can only live together, and they can only enter into force together. So what we have to do after the assembly, we will have to, well, we will set up, obviously, a new an expert group and then a new IGWIG to negotiate the PAPS. The timeline is not 1 year. The timeline is to report back to the next assembly. We wanted to have at least 2 years because we believe it's so technical, it's so complex to negotiate PAPS. It will take longer than a year, most likely. I mean, let's keep fingers crossed. But this is very, very complex. It became clear also in the negotiations that we are far away, partly, from one another when we discuss these concepts. Do we allow innovation? How we do we incentivize the pharmaceutical industry to participate, or how do we do this? And there are lots of things where I think we need to find a consensus, and this will take time, a year, maybe 2. But I think we will enter into these negotiations with everybody else who participated with full spirit and optimism that we, I mean, reached a major success tomorrow, the day after tomorrow, the conclusion of the agreement. And then hopefully soon the conclusion of the PAPS. And then, once we have that, I think that's also important to realize, we need 60 countries to sign it and ratify it. And then, I mean, also that will take its time. And the interesting part here is, the pandemic agreement and the PAPS will make no sense if it's only ratified by the global south, yeah, or only by the global north. Yeah? So this needs to be really a global thing, and I hope that really all member states who negotiate it in good faith will then in the end sign it and ratify it in 3, 4, 5 years.
Thank you so much, Bjorn. Anybody wants to?
Tuesday, it seems that we will agree that we have not yet agreed. The PAPS. And who in this room want the PAPS to be agreed, say, next month? Please raise your hand. And so that we have a pandemic agreement. No one? So why we continue to negotiate and discuss? No one in this room wants the pandemic agreement. But if anyone wants to have the pandemic agreement fully agree, it's very easy, fast also, very easy. You go to your lab, pick up the, whatever new virus and spread it around the world. Create a new pandemic. Then it will be much faster, right? If there's nothing like that, I don't think even 2 years. you may be able to agree. If you follow this negotiation carefully, many people, or even most of them, come with idealism rather than practical. Let me give you an example. They talk about benefit sharing, technology transfer. If look at COVID, how many countries can produce the vaccine and medicine? How many? Even if you want to transfer technology on mRNA vaccine to a developing country like Thailand, do we have the capacity to really receive the technology? And even if we have the capacity, when the pandemic passes, how can we maintain that capacity? Do we have to continue to produce vaccines? mRNA, which vaccine in mRNA? To maintain our capacity. This is realistic. But if you continue to negotiate based on idealistic way, you go nowhere. But as I said, spread a new virus. If it's not finished, then spread a new one. Then you have it.
Thank you, Sued. I am going now to turn to a question about WHO financing. So I'm going to go back to you, Björn. As the chair of the Sustainable Financing Working Group for WHO, you led a process with fellow member states to identify solutions to WHO's persistent financing challenges, including an over-reliance of a handful of wealthy donors. Thanks to your work and also the solidarity of member states, the decisions to increase assessed contributions and the outcomes of the WHO investment round have started to pay off. WHO has $320 million more in the bank at this point in the budget cycle compared to recent cycles. In the face of significant funding challenges, how can momentum be sustained to protect WHO during this dear time for global health financing? What is working and what needs to change?
Okay, so first of all, since the question brings more or less the illusion that we are in a better state than we were before with the 320, it's not the fact. So I think we are, compared to former biennia, what we achieved is more clarity of how much money we will have. But most likely not too much more will come. That's the depressing point here. So through the there were two main recommendations from the working group. The one was the AC increase, and we keep fingers crossed that we will have a consensus on this in the Assembly. It's not a give and take that will happen. I think obviously the African countries, I think the European countries, and many of the Asian countries are in favor, but there are also other countries who remain very quiet and who potentially do not want or have challenges in their domestic settings to argue in favor of a 20% AC increase. Yeah? This is not a small step. In other UN agencies, it doesn't happen at all. There's the general policy of zero nominal growth, so zero increase of the assessed contributions. So I think there is still work to do, even during this assembly, to lobby, and potentially you all can do that with your delegations or even with others who are not convinced yet, that this increase comes. It's a needed increase, because if we don't get this increase, WHO will be even in a deeper financial crisis. This is the money to pay the salaries. This is the money to pay norms and standards that nobody else pays. Yeah? So this is not an easy target, and it's, yeah, I think this is really something that we need to get out of this assembly, the AC increase. Now, but the other point that the working group recommended was the investment round. So basically, anybody in any member state or foundation, and there are also some here, can fund WHO through voluntary contributions. And the idea was to do this in a concerted manner. And we've done the investment round last year, and there will also be a session on the investment round, I think on Tuesday. So we hope that further member states, but also non-member states, such as foundations, will pledge. But so far, it's not enough, yeah, by far not enough. And it's interesting, and that's the point that I want to make, and I think we need to think about that, is if we're looking at the outcome of the investment round at this moment, you will realize that roughly 80 to 90% comes from one region. That's the region you find yourself in right now, as a voluntary donation, 80 to 90%. And only a very, very small portion comes from all the other regions together. Those are the African region, the PAHO region, and obviously CEARO and WIPRO and EMRO. So we have a complete disbalance in between the membership of this organization and the financial contributions. And that will not be sustainable for the future. Certainly not. So the emerging economies, we have one represented here, they need to come in. Yeah? And at that stage, I think also coming back to Jeremy, I think we are still living in the mindsets of 30, 40 years ago, yeah? Where many of those countries who are now able to contribute and should contribute still were developing countries or even least developed countries, but they need to come in. It's completely unsustainable if a number of 5, 6, 7 member states pays for the priorities of us all. Yeah? Plus, there is one region that doesn't contribute at all to the financing of WHO, at least through the investment round. Yeah? And we need to think, why is that? How can we incentivize that region to, I don't know, be more committed for WHO, even financially? I think politically they are, but there is this discrepancy in between what member states, and that applies to us all, how we all applaud the WHO for its importance, and we will hear lots of nice Sunday speeches tomorrow and the day after tomorrow, despite the fact that then it's not Sunday anymore. But if we then ask those political high-level decision makers, well, but what about increasing your resources to WHO? You will not hear too much, and I think we need to change that. But not focusing only on the traditional donors, but making sure that also others come in. Otherwise, it's unsustainable.
Thank you so much, Bjorn, for that important call to action to member states. I am going now to go to Suit, and I hope you'll please indulge us now with some crystal ball thinking that doesn't involve spreading a new deadly virus. With your deep and wide experience in global health diplomacy, so do you foresee an evolution in the way countries pursue their policy priorities in this new landscape? Will member states explore different strategies from bringing new ideas to the table and building a coalition in support of those ideas? Will the World Health Assembly look markedly different in 10 years?
The World Health Assembly has changed a lot in the past 30 years. You can see more agenda, more resolution. You can see more active involvement of developing countries who become middle income, very actively involved in the negotiation. And do you know why we have so many agenda and resolutions? I haven't done a real analysis, but majority of these draft resolutions were from the secretariat themselves. And they asked some of their friends in certain countries to take the lead to submit that agenda and resolution. Why they did so? With a resolution, they can, argue with the administration, donors, that, hey, there's a resolution, a mandate. I need more money to maintain my department. This is a fact that happened in the last 30 years. But for us, we feel that we need the resolution. Not for the WHO to do anything. Don't need anything from the WHO. But we, as the country, want this resolution to back up our policy. We can use the resolution to say to our politicians and the public that, hey, this is the resolution from the WHO. So we should do it. No need for anything, any money, any financial contribution or any financial tie or any staff from the WHO. When we are going to implement something according to the resolution, and we face difficulties from vested interest group in the country, we don't want anything from the WHO. Just a letter from the DG. A drop of an ink of the DG to sign a letter to our head of state, to our chief of the parliament, to our chief of political party. And we spread that in the public media. It put a lot of energy to the movement. Just a drop of an ink. How much does it cost? Nothing. But whether the WHO leadership dare to sign that kind of letter is a question. I leave it to your consideration. What kind of a global health institute we want? A fat, obese one that moves very slowly, or a small, lean one that moves fast and help us at the country. Now we are graduate. We are ready to solve our own problem. But we are facing lots of vested interest groups in the country, influential. Look at this World Health Assembly. How many side events organized by private sectors? How many of them? I was asked to speak at least in 2 of them. I said, yes, I'll go. With the condition that I won't eat your food, I won't accept travel expense or anything from you, independently. That I can do. But they are influential to the media and to the politician. And this is why we need name of the institute, Global Health Institute, trusted Global Health Institute with high social credit to support our movement at the country level.
Thank you, Suet, for offering that look into the future and sharing your experience so many years, as you said, being part of WHA every year. Okay, we're almost ready to go to the question for Q&A, but first a final question for Professor Kickbush. You've said previously that those with the money define the priorities, the metrics, and what success looks like. Do you think the definition of success in global health is changing as countries move towards stricter prioritization and more fulsome ownership of their own health agendas?
Yes, I do think what constitutes success is changing because there is, one strong movement in global health which is totally legitimate, which is about saving lives, and which is driven by a development agenda, by, key international foundations, etc. And it is a very, very important move. It's linked to organizations like Gavi, like the Global Fund, etc. We don't want people to die of preventable disease, full stop. That is clear. But there is another set of outcomes. And for me, again, they link to this norms and standards development. Do we establish rules of the game as the world changes? And I've already alluded to the developments in technology. Do we help as an organization ensure supply chains and set standards for how they are organized? Do we help countries through the rules that are set for WHO to establish production sites? Do we have different types of economic measures for success? And not just, a simplistic investments in health, create wealth. There are much more specific data and agendas that we need because, the global health industry, the global technology industry that are coming closer and closer together are some of the largest and richest industries in the world. And as far as I'm concerned, writing a framework convention on tobacco control was a walk in the park compared to trying to introduce regulations or at least guidance for member states in that direction. And as Suet said, we are seeing that member states are under continuous pressure from these kind of new power brokers in the world. And, some people have said data are the new oil. there is practically no data that are as valuable as health data. And the question, who has access to them, who shares them, how they are used, how they are extracted, how they are exploited, is one of the key questions we need to answer in the next 10 years. And for those kind of things, we need a trusted organization like the WHO that really also takes up these issues. And these are the new global challenges that need to be addressed, and probably we'll need new types of methods to do that. We'll need to revisit what a partnership means. We'll need, to revisit FENSA, I'm quite sure. But those are the issues that are not the future issues, they're happening here and now. And unless WHO, as that trusted agency, in my view, doesn't address it together with its member states, we're going to see a power shift in global health where, the comparison where some people are concerned about the power of certain large foundations, where, the power shift is going to be extraordinary about who defines the health agenda of the future, and it's not going to be us.
Thank you so much, Ilona. And with that, we're now ready to go to you in the audience. I see several hands up, so I'm going to take 3 questions. If somebody can help with a microphone, please. Okay. Go ahead.
Yes. My comment.
I cannot hear you. Can you please?
I hope it works now. My comment or question is addressed to Suvit. I think you mentioned the word Trump in your first statement. What Trump did was something he also did it during his first administration, that towards the end he canceled the aid or he kind of withdrew the same thing. I'm a bit surprised why the WHO did not foresee that as something which was possible and there was no plan B which was there. My specific question is, tomorrow if Trump makes a complete U-turn, which he's capable of as he has seen with the other things, will these serious reforms which are going on with WHO, not in WHO, will they continue or the discussion will gradually fade out and back to the earlier situation?
Thank you for your question. I think there's another question here. Oh, go ahead.
Great. Hi, I'm Kirsten Gagne with Kati Collective. Bjorn, I liked your comment about thinking about WHO as kind of a facilitator rather than competitor. And I've been thinking a lot about across the global health initiatives, across the GHIs, and particularly the Lusaka agenda. And I'm curious how any of you think that WHO might be able to be a facilitator to help the GHIs become more of collaborators rather than competitors, and become collaborators with WHO instead of competitors. I've seen competition across the GHIs and across the GHIs with WHO, and just wondering how WHO might be able to facilitate that as a more collaborative, efficient set of organizations as well.
Let's take one more question. And go ahead.
Hi, Elaine Fletcher from Health Policy Watch. As I've been covering the budget crisis and the different options that are being looked at, one thing that struck me over and over is the fact that WHO doesn't publish actual cost data of different positions. They publish salary data, but the salary, as we all know, is only between 30 and 37% of the actual cost of the position, and it depends by location and grade. So Bjorn, I'm asking you, how come member states don't demand more disaggregated data if we're talking about transparency and all these very difficult trade-offs, so that, I mean, we're not going to turn a member state representative into a modeler, but still you would have a better idea of what those trade-offs are if you could see the actual data disaggregated and not simply, as we've seen it traditionally. Thank you.
Thank you. Okay, I'm going to now give our panelists the opportunity to respond to the questions about, if you recall, there's 3 questions. One's about what happens if Trump makes a U-turn, where actually serious reforms will still get underway, and the role of WHO as a facilitator, instead of a competitor with global health institutions, and about the ask for member states to put some pressure for more transparency on the data, cost data that they will share.
And I should start. Okay, good.
Please.
So I'll take all three of them, but leave enough space for my colleagues. So with regards to the U-turn, I think it would be a complete misunderstanding if the financial mess we are finding ourselves in WHO was only linked to the US vanishing. I think that's a big part. But I think the growth of WHO, the Fed that was alluded to, obviously came also over COVID. I think the WHO is bad in setting priorities. I think it was at some stage in November, I was here for the INB. The election outcome was as it was. And the first thing I did was address the senior management and said, well, what's your contingency plan? How do you set priorities now? And big question marks. This organization is not good in setting priorities. Why? But there's also a link with finances here. Because to some extent, the priorities are set by donors, not primarily non-state donors, but also countries who earmark their resources for very specific pet projects, which then are a priority for WHO. But this is not the way to do it. So again, it's also linked to the AC increase and the need for flexible resources. You can only shift money to your priorities if you have obviously flexible resources. So parts is, so I would say for sure not. I mean, even if there was a U-turn, which we all hope for, I think the reforms need to go on. I think a smaller size of the management is needed, clearer focus, obviously, on results, clearer focus on WHO's comparative advantage. But that's not a new discussion that we have. This is a discussion that we had at least for 5 years. But it's also a reality that as hard as it is for the Secretariat to set these priorities and to clarify what are the comparative advantages of WHO vis-a-vis Global Fund, Gavi, etc., it's also the member states have different visions. Yeah? If you're talking to Germany, it's very clear. Norms and standards, coordinating role, data. Yeah? But if you talk to another country, it might be something completely different. Yeah? So coming to terms and to a consensus, I think would need a strong leadership from WHO. I think that we now have that with the new senior management, and then obviously also feedback from member states. Second question, Lusaka agenda. The one thing that completely worries me is, I mean, and Jeremy said that, the global health architecture in 2 years will look completely different. In the World Health Summit, it's not even, now it's maybe a half a year ago, we had a session which I think I was shaping more or less the title, which was Mergers and Acquisitions. And people were completely angry because of that title, because it basically says, some of those in Geneva existing agencies will not exist here in the future. And that, back then, it was criticized. I think now it's more or less the common agenda. It's very clear that from Gavi, Global Fund, UNAIDS, WHO, I think we will not see 4 of those in the near future. Unclear when. It's going to last longer than a year, but I think that's the right debate that we need to have as soon as possible. And the big question that you need to ask yourself, where is space for this debate in the World Health Assembly, which is supposed to be the forum where we discuss these issues? It's not there. There is one side event tomorrow at lunchtime, interestingly, hosted by a couple of countries. But apart from that, and obviously there are further side events outside, but it's not on the agenda itself, which would make sense. But obviously there's also the question, is WHO the right forum to have this? WHO is the forum of health ministry. I'm a representative of a health ministry. Gavi is to a large extent not run by health ministry. It's run by foreign ministries or development ministries, and Global Fund too, etc. And other ministries will be in charge of others. So is the Assembly the right forum to discuss these global health architecture issues, or do we need another forum? And WHO, indeed, my criticism towards WHO would be, just because Article 1 of the WHO Constitution says you are the leading agency, you're not leading. I mean, it's just because it says it, you have to lead by example. You have to jump in, you need to be on top of the debate, you have to convene, you have to facilitate, obviously not in an aggressive mode or competitive mode, but rather, I mean, getting everybody together on board into a room with the right, sometimes it's also about characters who are involved, yeah, in these, it's about, do I like the leading person here or there, but certainly I think given the fact that the funding is very limited and it doesn't make sense to have a replenishment for WHO on Monday, then on Tuesday for Gavi, another one, and on Wednesday for the Global Fund, I think we need to see them together. We need to discuss their mandates. Where do they end? Do we need all of them? And I think, that debate needs to come up as soon as possible. And the last question, Eileen, I think you are absolutely right. I think we member states do a bad job in providing oversight and guidance to the Secretariat on many things, including aggravated data. I'm not sure whether only the personal is the right thing. What are the key cost drivers for WHO? Is this headquarters? Yeah, I'm aware of the cost drivers within headquarters, but maybe in other regions, where are the cost drivers? Can we still allow 6 regional offices to exist? Yeah, potentially we can't afford them anymore. Yeah, and where are they located, in high-cost areas or not? I think that obviously we need to debate. I would urge not to do that completely open. I think we need to have a PBAC that can constructively engage with the Secretariat, and I think I would certainly avoid micromanaging, trying to micromanage an organization such as WHO. You need to do this on a trustful basis with the Secretariat. For that, we have the PBAC. But is the PBAC really functioning? And I would say no. Neither does the board nor the Assembly. I think we also have to reform those and the role member states play. In the PBAC, we've asked lots of nasty questions. We haven't received too many answers, but I think obviously we need to push further.
Thank you.
Often enough, it's appreciated by the Secretariat.
Thank you so much, Bjorn. I don't know if Ilona Sweet want to add anything.
Well, the question is why no one in the WHO anticipates what is happening. If you are obese and sit sedentary in your chair, and then people feed you all the time, do you expect that one day you'll be lean and fit? No. It's happy to be obese and eat sweet and nice fat food and don't move. It's time to do that. Not by the obese people themselves, but by those who feed them, to stop feeding them. Stop feeding them. Don't worry, they will not die. And even they die, don't worry. I'm not sure whether the WHO is still a trusted global health organization. Look at the COVID-19 is a good example. In 2020 and 2021, if you go to the WHO website and type travel restriction, travel recommendation, you see that WHO recommend against travel restriction. Until mid-2021, the text still there, recommended against travel restriction. Which member state listened to them? Which one? None. In spite of the fact that I sent many notices to senior official administrator, hey, no one listened to you, why you still recommend that? Then the WHO recommend not to use face mask, right? Anyone listen to them? When we start to have vaccines, the fact that the first vaccine came, we give the first dose, and when it's time to give the second dose, the vaccine didn't come, but a new vaccine come. We have to use the new vaccine for the second dose. The WHO said, no, don't do that. Don't switch vaccines. In practice, who listened to the WHO? COVAX is a good example of failure, global failure. Thailand is one of the 10 countries that didn't join COVAX. I was asked by my government, hey, whether we should join. Our foreign ministry said, yes, you should join. It's a global image that you are a good global citizen. I call my connection in Gavi, in UNICEF, and in the WHO who work on this. Hey, give me, very, very clear and good advice whether we should join. I received more or less the same not the same text, but the same advice, you would be stupid to join. I asked why. Because you not get the vaccine you want, and you have to pay the money. And that happened in so many middle-income countries that join COVAX. At the end of the day, they give you the list of vaccine that they have in hand, but the vaccine that your people want and you want is a different one. So you end up with negotiate bilaterally for a different vaccine. But you have commitment with COVAX. You have to pay them. And at the end of the day, don't send the vaccine to us, we donate to you. And how much of the vaccine, donated vaccine, were thrown away? I'm not saying that it's not a good intention to do it, but it's a failure. We need a new global health institute, not this current WHO. And don't try to reform. In the last 30 years, I have listened to many DG. We are going to reform, we are going to transform. All cosmetic and become more obese and obese and obese. And this is the situation we face now. I'm not saying that we don't need a global health institute, but not like this one. And we cannot reform it. It can only be reborn. And people came to me and asked me, what kind of global health institute you want to see? I said, I won't talk to you. Because if I propose anything, you hit what my proposal and leave this organization to continue as such. And there will be nothing to change. That's why I thank Trump. And I thank him not only because he quit with the WHO and not pay the WHO, but also he quit to support NATO, which means the European country has to put more money on defense and less on development assistance for health, including the WHO. A good sign. Let's see what happens. The future is not ours to see. Let it be in our own hand.
Thank you, Soed. I think we had a few more questions. Oh, Laura, go ahead, sorry.
I would like to say something about obesity. That is, that your criticism of WHO in terms of, basically being strategically blind, I would agree with, but I also would say, looking at the other organizations, they are not much different. I mean, if you looked at the new proposals for the next investment rounds of the Global Fund or Gavi, with, billions of additional dollars that were wanted, and you also ask yourself, these organizations have governance mechanisms, they have boards. You usually only see their CEOs. You don't know much about their decision-making structures. These decision-making structures were heralded as the big new thing in global health because they were multi-stakeholder. And, in the end, all the money came from the countries and the same old countries again. So I think, that obesity problem, point one, went much further. And part of the reason the cooperation has also not functioned is because the minute also the WHO entered the financial competition train, who's going to give the money to whom, then it got really complicated. I mean, I was working in WHO when UNAIDS was created and the WHO AIDS program was closed down. And I do think, that having something like the Global Fund was better than having that WHO AIDS program that was existent at one point. But the fact is that, it doesn't only take two to tango, it takes a whole range of members of this ecosystem to actually have a willingness to cooperate. And when Angela Merkel was Chancellor of Germany, she initiated the SDG 3 action plan, which was exactly to do this, to get the organizations to talk to each other. And it was a total failure. because no one was willing to talk to each other, and definitely not, at the invitation of the World Health Organization. So I think the first step does have to be that WHO becomes clear what it does, and then the challenge is put forward that the boards of these organizations actually are challenged to look at what their organizations are doing, which, have collected an enormous amount of fat, a constant mission creep that has been going on there. So, it's right to criticize a lot of things about WHO, and having worked there, I'm one of the first to do so. But to not look with the same seriousness at these other organizations is not correct. And nobody is doing that, because also of some of the powers involved, because how the funding of those organizations is practiced also relates to the funding of a lot of other health initiatives, of health research programs, of all kinds of things that are interlinked. And so I think that needs to be a new type of agenda that one takes forward. We actually suggested a mechanism called Committee C at one point that would start doing that. But of course, it's within WHO. But I still think it's worth a try to have a committee that actually explicitly looks at global health cooperation and the ecosystem.
Thank you so much to all our panelists. We have arrived at the end of our time for discussion. I want to thank everyone. But before we conclude, I'll invite to the stage to join us, to close us out, stage Vinh Kim Nguyen, who is the co-director of the Global Health Center at the Geneva Garden Institute. I wanted to please thank our panelists for that, and please join us with an applause for them.
So I also want to thank our panelists, Cecilia, the UN Foundation, the Global Health Center. It's been, I think, a very interesting opening briefing. I'm just going to say three things and sort of try and summarize what we've heard here. The first is that this is a historic event, this World Health Assembly. That's not a cliche. It's the first time the U.S. apparently will not be attending. We have, despite that, an historic agreement that we've heard. There's and some legal improvisation occurring around that. And I think what we've heard also, and we really can't underestimate, is that everything has changed. So it's tempting to, or the lightning rod for that has been President Trump, but a lot of things have been happening that we have not been seeing or have not recognized within our broader global health community. So not just WHO, there's been a collective failure of global health governance, and this is on us, all of us, myself included. And what we have to be able to do is to see, and this is just me saying this, or not just me, but the big picture, that global health is at the center of geopolitics today. It always has been, if you look at the history, and we'll be doing an event on that Monday, but more so than ever. And we are in a radically different world, as Jeremy and Bjorn and Ilona and Suvit and others have stressed. A lot has changed. We're still kind of functioning with almost a just post-Cold War paradigm. And so we really have to open our eyes. Technology, medicine, geopolitics, all this has completely changed the game. So we have to be really on our toes. And so with that, I'm going to just mention that we are having 3 events, side events, at the same time, same place, same food, kind of. Well, next door, but same place. Tomorrow is on soft power, geopolitics, and financing at the WHO from 1945 to 2025. I think it's very useful to get the historical perspective because the world has changed, but a lot of the functioning has been going on since the last 80 years. We're having an event on the pandemic treaty. You may have heard about that on Tuesday. And on Wednesday, on something that's also been overlooked, but I think is very important, the plastics treaty, which is remarkable because it's a coming together of the environmental and global health constituencies, and we all know how important environment is. So I welcome you to come to those events. You can register at ghplatform, allstucktogether.org. And without further ado, I invite you to our reception behind, upstairs, and good luck, hard work.